Good morning, delegates and participants. Thank you for joining Shield Connect. Today, we are back with the Chennai Menopause Society webinar, and they sponsored a webinar on menopause basics and beyonds, along with the change, not challenges, and Department of Obstetric and Gynecology of IGIMS Patna. So, we invite you for this webinar, and I will hand over the session to our matter of ceremony, Dr. Swati, Assistant Professor and Obstetric Gynecology of IGIMS. Ma'am, I hand over the session to you, ma'am. Thank you, ma'am.
Thank you. A very good morning to all of you. Myself, Dr. Swati, on behalf of Chennai Menopause Society and IGIMS, I welcome you all for the talk on menopause basics and beyond. For welcome address, I would like to hand over to Dr. Professor Neeru Goyal. She is alumni of PHU 1991 batch, and she has got 25 plus years of teaching experience. Presently, she is working as professor and head of department at IGIMS, Department of Obstetrics and Gynecology, Patna. She has been guide to several postgraduate students. She has worked at short service office with Army Medical Corps for 10 years, which has given her vast experience and made her adjust to any situation. She has many publications to her credit in national and international journals. Over to you, Neeru Goyal, ma'am.
Thank you, Dr. Swati. आप अपना वीडियो ऑफ कर दो. Thank you, Dr. Swati. The idea, good morning, Dr. Hepsiba and everyone. The idea of this meeting is the result of just a casual talk with Dr. Hepsiba when she came for a guest lecture to our institute on 27th of May. And Dr. Hepsiba readily agreed or accepted this to conduct this webinar. Menopause, no one likes this word, but the fact of life is that now nearly 1/3 to half of life is spent after the menopause. The ladies are nearly 25 to 30 years by the time they complete their education and settle in their profession. And by the time they think of starting their family, the ovulation function is already going down, and then they become desperate. Nearly 50% of the patients coming to gynae OPD are of perimenopausal and menopausal age, and they have symptoms of vasomotor, genitourinary aches and pains besides AUB. They keep getting investigated and treated for UTI without us realizing that they are suffering from genitourinary symptoms. We think that the sexual life is not for them, though it is a very, very important part of marital life. 40 to 45 years of age is nothing, and we also know that men are sexually active till 60 to 70 years of age. And we must take care of this aspect of life of these females as it affects the marital life. We, being from medical college, also have the responsibility of training PG students, and this talk is designed keeping them in mind. Some basics of menopause and its management. Now, Dr. Swati will be introducing the first speaker, Dr. Jyotsna.
Thank you, ma'am. Am I audible?
Yeah.
Yes.
Yes.
Our first speaker is Dr. Jyotsna Pathak, ma'am. She is working as assistant professor in Department of Obstetrics and Gynecology, IGIMS Patna, since December 2020. She has worked in several areas of Bihar. Before this, she was working in WIMS Pavapuri, and she has been in Bihar Health Services for a long time. She has done her MBBS and MS Ops Gynae from PMCH Patna, which is an esteemed institute in our country. And she will be speaking upon the basics of menopause. So I'll hand over the screen to Dr. Jyotsna Pathak, ma'am.
Thank you, Dr. Swati, for the kind words. First of all, good morning, everyone. First of all, I thank the organizer, our HOD ma'am, Dr. Hepzibah ma'am, to give me the opportunity to speak on this forum. I will be speaking on basics of menopause. Menopause is a normal phase of life. It has to come in everyone's life, but it is we should welcome it. It is a welcome change, as there will be no further menses, no worry of premenstrual syndrome, no worry of any accidental pregnancies, therefore no need of contraception. It is an opportunity and therefore an obligation for the clinicians to provide preventive health care to all the women at this point of time. Median age of menopause is 51.3 years, according to the study done at Massachusetts in USA. But in India, the age is a little less. It is 46 years, done by as shown by the meta-analysis done by Devi Prasad et al. In 2021. The menopause is apart from smoking, which decreases the age of menopause by 1.5 years. The menopause age is not affected by the use of the marital status, any other causes. Women after menopause will live greater than a third of their life beyond menopause. Therefore, it is important that these years are as healthy and productive as possible. Menopause is derived from a Greek word men means month and pauses means cessation. Menopause is defined retrospectively as a time of final menstrual period followed by 12 months of amenorrhea. Climacteric is an older, less precise term and indicates the period when a woman passes from the productive stage of life through the menopausal transition and menopause to the postmenopausal year. Perimenopause is a new term that includes the year prior to final menstrual period, during which the cycle progresses from regular ovulatory predictable cycle to irregular and increasingly anovulatory cycle to eventually cessation of menses. It should be kept in mind that no specific test is recommended to diagnose menopause. It is diagnosed only clinically by the irregular menses, but one should be kept in mind that if there is irregular prolonged bleeding, one should investigate them. Staging of reproductive aging workshop, STRAW has given criteria to define the various stages of the reproductive aging. In 2010, STRAW plus 10 criteria was updated to reflect the advances in changes in the hypothalamic pituitary function occurring throughout the reproductive aging. The STRAW staging has divided the female lifespan into three broad phases: the reproductive phase, the menopausal transition, and the menopausal phase. These three phases are further subdivided into 7 stages. The main event is the final menstrual period, and 5 stages is before the final menstrual period, and 2 stages follow it. This is given by adapted from Harlow et al. And this shows the same thing. The 3 stages: the reproductive age, the menopausal transition, and the postmenopausal stage. The late reproductive stage is the STRAW stage -3, and is further subdivided into 3A and 3B. In 3B, the menstrual cycles are regular, but in 3A, the menstrual cycles become shorter. The FSH increases, AMH, antral follicle count in even B decreases. In the early menopausal transition, which is the STRAW stage 2, the length of the menstrual cycle starts increasing by more than 7 days. In the late menopausal transition, it is the straw stage -1. The length of the cycle further increases to more than 60 days, and the FSH is more than 25. Hot women starts having hot flushes. In the early postmenopause stage, the straw stage 1, the FSH starts to rise, while the estradiol declines 2 years after the final menstrual period. The straw stage 1 is further subdivided into 1A, 1B, and 1C. 1A and 1B last for 1 year each and culminates once the fluctuation of the FSH stabilizes. Vasomotor symptoms are more common in these two stages. In 1C, elevated FSH and low estradiol becomes the new normal, and this is lasts for 3 to 6 years. This is the opportunity where we have to intervene and free the women, menopausal women, from all the worries of Late menopause stage is the stage 2, where the hormone level plateaus. Vasomotor symptoms are less, but vaginal dryness and urogenital symptoms are more prominent. This is a transvaginal picture of the ovary. You can see in the premenopausal stage ovary, many follicles can be seen, but in the postmenopausal ovary, it is devoid of all ovarian follicle. So the most important, the post process of the atresia of the non-dominant follicle is the prime event that leads to eventually the loss of ovarian activity. In this, the vaginal smear, which is taken from the lateral wall of the vaginal wall, you can see when the estrogen is present, there is predominant of the superficial or the superficial and the intermediate cells, but there is predominance of the parabasal cells in the menopausal women. And there is a shift to the left in the maturation index. Now coming to the endocrinology and the physiological changes during the menopausal transition. There is depletion and resistance of the ovarian follicle. Due to depletion of the ovarian follicle, there is fall in the serum estradiol level, which causes increase in the follicular stimulating hormone and luteinizing hormone, and decrease in the AMH and inhibin B. Ultimately, no follicles are available, and even if they exist, they become resistant to the gonadotropin. Estradiol level production drops to 20 picogram per liter. There is no proliferation of endometrium, it becomes atrophic, and finally menopause ensues. This is the hormonal change. You can see the level of the FSH and the LH has started to increase after menopause, and the level of the estradiol has gone down, and the main hormone in the menopause is the estrone. Androgens, the main androgens which is secreted during the menopause in the androstenedione and the testosterone, which is secreted from the ovary. The adrenals secrete DHEAS, androstenedione, testosterone. After menopause, the stromal cells of the ovary produce androgens due to increase in luteinizing hormone. The main androgens are androstenedione and testosterone. The androgen is converted to estrone in the adipose tissue. However, the cumulative effect is decrease in the estrogen-androgen ratio, and this results in increased facial hair growth and change in voice. Physiological change of menopause are the consequences of change in both the ovary and the hypothalamus. The ovary does not produce estrogen, so the follicular stimulating hormone and the LH continue to rise, and there is decrease in the inhibin and the estradiol. This causes osteoporosis in bone, atherosclerosis in cardiovascular system, and atrophy of the vagina, breast, and the uterus. In hypothalamus, the estrogen, due to deficiency of estrogen, there will be insomnia, mood swings, hot flushes, and depression. Estrogen receptors alpha and beta has been much studied nowadays, and they are the nuclear transcription factors that are involved in the regulation of many complex physiological processes in the human. They modulate the physiological function of estrogenic compounds. These compounds have action in cell nucleus, regulating the transcription of specific target genes by binding to associated DNA regulatory sequences, and they control key physiological functions in various organ systems such as reproductive, skeletal, cardiovascular, and central nervous system. This is the molecular action of the estrogen, how the estrogen acts on the cell. The estrogen is present in the circulation, it diffuses inside the cytoplasm, and then it combines with the estrogen receptors in the nucleus, and then there's interaction of the hormone receptor complex with the nuclear RNA. Then mRNA is produced, and this is transported to the ribosome, and from ribosome the protein is synthesized, which is responsible for the specific nuclear activity. These are the target organs where the estrogen act. You can see the central nervous system, cardiovascular system, breast, liver, GI tract, urogenital tract, and the bone and uterus, urogenital are the specific sites where the estrogen act. And these are the estrogen receptors. It is present in the almost all the receptor alpha beta receptors are estrogen receptors are present on almost all tissue, but in uterus and mammary gland the alpha receptors are more prevalent. Most tissues expresses both subtypes, but estrogen receptor alpha predominates in the uterus, vagina, breast, bone, hypothalamus, and blood vessels. Estrogen receptor alpha has more prominent role on the mammary gland and the uterus, as well as preservation of skeletal homeostasis and regulation of metabolism. Beta receptors are present mainly in the bladder, granular cells of the ovary, colon, adipose tissue, and immune system. They have more profound effect on central nervous system and immune system. Estrogen receptor beta generally counteracts the estrogen receptor alpha promoted cell proliferation in the tissues such as breast and uterus. Both subtypes are markedly expressed in cardiovascular and the central nervous system. Development of and the function of the ovary and the protection of cardiovascular system is done by both receptor subtypes. Beta receptors stimulate the nitric oxide production from the endothelium, and thus they protect the blood vessels from atherosclerosis and have beneficial cardioprotective effect. Beta receptors play an important role in regulating metabolic pathway adipose tissue function, showing beneficial effect of estradiol on hyperglycemia, oxidative stress, and on the liver dysfunction. Research is going on for selective estrogen receptor beta activators, since they are considered likely to be safer than the non-specific estrogen due to lack of stimulation of estrogen receptor alpha. Estrogen receptors, and particularly estrogen receptor beta in particularly, play an important role in skeletal muscle regeneration processes after injury. Certain ligands, the estradiol or the phytoestrogens, they bind with the receptors and behave in a different way. Like estradiol has affinity for both the receptors in a similar way, but phytoestrogens, for example, genistein, have greater affinity for estrogen receptor beta than for alpha, and this is used to in therapy to improve the cognitive function. Ligand binding with the selective estrogen receptor modulator SERMs, they act. These drugs exert estrogenic as well as anti-estrogenic action in the tissue selective manner. Agonist binding to the ligand binding domain brings receptor dimerization and interaction with the estrogen receptor elements, and the gene transcription is promoted through co-activator gene. But when they act as antagonist, then the receptor assume a different conformation and interact with the co-repressor gene, co-repressor protein inhibiting gene transcription. For example, raloxifene has agonistic action on bone and lipid metabolism and on cardiovascular system, but antagonistic action on endometrium and breast. So to summarize my talk, menopause is a transition in women's life, and the staging of menopause transition should be done using straw plus 10 criteria. Atresia of the ovarian follicle is a primary event that leads eventually to the loss of the ovarian activity with irregular menstrual cycle. AMS should not be used to diagnose menopause. Physiological changes of menopause are consequences of the changes in both ovary and hypothalamus. Deficiency of estrogen is the cause of the possible effects at various target organs. Most tissues express both subtypes, but estrogen receptors are predominantly in the uterus and the breast. And different ligands have differ in the affinity to alpha and beta, and the SERM, and this is used in the drug which is very much commonly used, like litroxipin, which has agonistic action on bone and lipid metabolism and antagonistic action on uterus and breast. Thank you.
Thank you, Dr. Jyotsna. It was a very wonderful introduction about menopause, about the basic of menopause, and we got vast information about it. Now, we'll be moving to the next session, that is the consequences of menopause.
Our next speaker is Dr. Ranjana, who is working as assistant professor in the Department of Obstetrics. She has worked at Delhi in MD and professor at Indira Hospital. She also worked at Mass Hospital. She was
Is it audible? It's not audible. Jyotsna. Slides are moving.
We cannot hear you, ma'am.
Jyotsna, we cannot hear.
Should I start from beginning or continue from this
Yes,
slide?
ma'am. Start from the
Yeah, we have
beginning.
not
I
heard so
think
far anything.
yes, we cannot hear you.
Okay. Swati. Should I start from beginning?
Yeah, better, madam, better.
Better. Today I'm going to highlight the consequences of menopause. The major consequences of menopause are related primarily to the estrogen deficiency. But it is very difficult to distinguish the consequences of estrogen deficiency from those of aging, because aging and the menopause are inextricably linked. However, the period of menopause transition so serve to remind both the patient and the clinician that this is the time for communication to ensure improvement in the patient awareness through education. Though the preventive healthcare education is important throughout life, but at the time of menopause, a review of the major health issues can be especially rewarding. Principal health concern of the menopause women include vasomotor symptoms, urogenital atrophy, osteoporosis, cardiovascular disease, cancer, psychiatric symptoms, cognitive decline, and the sexual problem. But again, it becomes difficult to distinguish whether these symptoms are because from the loss of ovarian function or from those from the aging processes or from the socio-environmental stresses of the midlife years. Many symptoms are found related to the postmenopausal syndromes: hot flushes, irritability, mood swing, insomnia, dry vagina, difficulty in concentration, mental confusion, stress, urge incontinence, osteoporotic symptoms, depression, headache, insomnia, etc. Dr. Josna has already described the various target organ for the estrogen axis. Now, this diagram is showing the manifestation of different system of a female body after menopause. This is the diagram showing the consequence of low estrogen level during the various stages of the menopause. The symptoms of the mood swings, cramps, weight gain, nausea, night sweats, insomnia, that all are appreciable since the perimenopausal time. And the osteoporosis, urinary infection, and the incidence of the coronary heart disease, they are more prominent during the postmenopausal phase. Now, one by one, I am describing the symptoms and the consequences of the menopause. Vasomotor symptoms, this is the hallmark of the female climacteric. Hot flushes typically begin as a sudden sensation of heat centered on the face and the upper chest that rapidly become generalized. The incidence of hot flushes is seen in about 75% of the women. It varies in frequency, intensity, and duration, and it can last from 4 to 10 minutes and vary from 1 to 2 and 1 to 2 episodes per hour and the per week. It can manifest at night as the night sweats, and the disturbed sleep is significant. And it may be associated with the palpitation, anxiety, irritability, and the panic. The incidence of the hot flushes was seen in the 10 to 20% of the premenopausal women and in about 60% of the perimenopausal women. While its incidence among the postmenopausal women, there was no flushing in 15 to 25% of the cases, and daily flushing was observed in again 10 to 15 to 25% of the cases. The duration of hot flushes among the postmenopausal women was observed for 1 to 2 years in average in 50 to 20% of the cases, and the 5 or more in 25% of the cases. But in the patient of menopause, in the menopausal female, if the symptom of the vasomotor symptoms persist, then the other causes must be excluded, like the psychosomatic cause, stress, thyroid disease, subacute, chronic infection, pheochromocytoma, carcinoid, etc. When do vasomotor symptoms occur? Usually begin during the menopause transition. The mean duration of the bothersome vasomotor symptom was observed for a period of 10.2 years. It can persist from 6 months to 10-year plus years with a decreased frequency and intensity over time. Some women experiences it for more than 11 years. Hot flushes, the grading of the hot flushes vary among the postmenopausal women. It can be mild, it can be of mild grade where there is a feeling of heat only without sweating. In the moderate grading, there is a feeling of heat with sweating. And in the severe grade of the hot flushes, there is a feeling of the heat with sweating, palpitation that disrupt the usual activity. This is the flow chart showing the pathophysiology of the hot flushes. There is a narrowing of the thermoneutral zone. And these all hot flushes occurs because of the hypothalamic response of the increased norepinephrine as a result of hypoestrogenemia in the menopausal female. This is the sequence of events whenever a female develops hot flushes. Initially, there is an increased core body temperature, increased skin blood flow, increased heart rate. Followed by there will be the intense feeling of heat with the reddening of the upper body. Then there will be the increase in the heart rate peak, increases in blood flow peak and sweating, and finally culminate as the chills and shivering. The second most important symptoms of the menopause is the genitourinary syndrome of the menopause, which is usually a late feature of the menopause. It is categorized as the genital symptoms, sexual symptoms, and the urinary symptoms. Among the genital symptoms, it could be vaginal dryness, irritation, burning, itching, leukorrhea, thinning, graying of the pubic hair, vaginal pelvic and pressure, and the vaginal wall prolapse. Among the sexual symptoms, there can be dyspareunia, reduced lubrication, post-coital bleeding, decreased arousal orgasm, desire, loss of libido arousal, and the dysorgasm. Among the urinary symptoms, there could be dysuria, urgency, stress urge incontinence, recurrent urinary tract infection, urethral prolapse, and the ischemia of the vaginal trigone. This is the diagram showing the atrophic changes in the vagina while doing the colposcopic examination. And this vaginal atrophy is really a feature of the late menopause. Due to estrogen deficiency, there is a thin and paler vaginal mucosa. There will the moisture content become low. The pH of the vagina become more than 4.5. And in the premenopausal state, where the vaginal epithelium will well estrogenized, there is a increased ratio of superficial to the basal cells of the surface epithelium, while in the postmenopausal state, because of the low estrogen content, there is a reduced ratio of the superficial to the basal cell of the surface epithelium. Symptoms such as vaginal dryness, vulvovaginal irritation, itching, and the dyspareunia are experienced by an estimated 10 to 40% of the postmenopausal people. Remember, unlike the vasomotor symptoms, which abate over time, vaginal atrophy is typically progressive and unlikely to resolve on its own. Regular sexual activity, lubricants, moisturizer, and the local vaginal estrogen is useful. Regarding sexual health, sexual issues generally increases with aging. Distressing sexual complaint peak during midlife and are lowest from age 65 onward. Decreased estrogen causes a decline in vaginal lubrication and elasticity. Decreased testosterone during menopause may contribute to a decline in the sexual desire and satiation, and active sex life, lubricant, moisturizer, and local vaginal estrogen help maintain the vaginal health. Don't forget sexually transmitted infection screening, because vaginal atrophy in the menopause state increases the risk of contracting an STDs. Regarding cancer, menopause per se is not associated with the increased cancer risk, but because cancer rates increase with age and the cancer is the second leading cause of death in the women, screening for the following cancers should be done on the regular basis. For the breast cancer, mammography is advised an interval of every 2 years. For the colorectal cancer, colonoscopy every 10 years, fecal occult blood test, sigmoidoscopy, or barium enema every 5 years, beginning at the age of the 50. If the any menopausal female presented to me with the postmenopausal bleeding, then endometrial cancer should be evaluated based on the finding of the pelvic ultrasound and by doing endometrial biopsy. For ovarian cancer, though there is no satisfactory screening test, but timely evaluation is needed if presenting with the bloating, pelvic pain, or urinary urgency. Pap smear test should be done at an interval of every 3 years or every 5 years if the combined with the HPV test after a normal report 3 years in a row for a woman ages 50 to 64 years. Screening is not necessary in a female if age is more than equal to 65 years, provided there is 3 or more normal pap smear tests in row, no abnormal pap in the past 10 years, or 2 or more negative HPV tests in the past 10 years. Osteoporosis, again a feature of late menopause. Following menopause, there is a loss of bone mass by about 3 to 5% per year. serious health threat for the aging postmenopausal women by increasing risk of fracture, mainly vertebra, femoral leg, and the wrist. All estrogen inhibits the osteoclastic activity and inhibits the release of interleukin-1 from the monocytes and hence prevent osteoporosis. Lower estrogen level accounts for about 2/3 of the bone loss during the 5 to 7 year around menopause. And osteopenia is defined based on the bone mineral density finding as a T score less than equal to minus 2.5. This is the diagram showing the bone loss with the aging. The rapid bone loss was seen between the 50 to 60 year of age, within 10 years after menopause. And after that, bone loss become less rapid. These are the risk factors for the osteoporosis in the women. Risk factors are family history, age more than 65 years, Asian and white races, lack of estrogen, low BMI, fragility fracture, osteopenia, osteoporosis, hypogonadism, fall risk factor, early menopause because of surgery and radiation, dietary deficiency, sedentary habit, certain medications like heparin, corticosteroid generation analog, anticonvulsant, diseases like rheumatoid arthritis, hyperparathyroidism, malabsorption, multiple myeloma, and thyroid disorders. This is the flow chart showing the pathogenesis of postmenopausal osteoporosis. Due to age-related changes, there is a vitamin D deficiency. There is a decline in intestinal calcium absorption and the impaired renal synthesis of 1,25-hydroxyvitamin D. And simultaneously, because of reduced physical activity and the sarcopenia, there is a loss of mechanical stimulation of the osteocytes and the decreased bone formation. All these deficiency of calcium, vitamin D result in the secondary hyperparathyroidism and the increased bone resorption. Along with, due to estrogen deficiency in the menopausal period, there is an increased osteoclastic activity. There is increased osteoclastic proliferation, the maturation, because in the increase in the rankle activity, leading to all this, leading to low bone mass and the loss of the bony architecture, leading to low fracture trauma. Cardiovascular disease. The heart disease risk rises for everyone as they age, but for the women, the symptoms can become more evident after the onset of the menopause. Menopause doesn't cause cardiovascular disease. However, there is a certain risk factor that got increased around the time of the menopause, and a high fat diet, smoking, or the other unhealthy habits begins early in the life can also take a toll. Identification and treatment of all the CSD risk factor is essential for the prevention of cardiovascular disease. This is the flow chart showing the consequences of the menopause on the cardiovascular system because of the aging, leading to the physical inactivity and ultimately leading to the obesity. And because of the hypoestrogenemia during the menopausal period, there is a certain indirect effect because of the changes in the lipid profile and the insulin resistance. And there is a direct effect of the hypoestrogenemia in the vasculature also, leading to the activation of the renin-angiotensin system, increase angiotensin 2, increase in the endothelin-1, and the decreased nitric oxide synthase. All these leading to the oxidative stress, vascular cell proliferation, vascular wall inflammation, arterial stiffness, endothelial dysfunction, ultimately leading to the atherosclerosis, and then become increased chances of the ischemic heart disease and the stroke. This was an article. The title was Vasomotor menopausal symptoms and the risk of the cardiovascular disease, a pooled analysis of the 6 prospective study that were published in the American Journal of Obstetrics and Gynecology in the 2020. This article has concluded that severity rather than frequency of the vasomotor symptom, hot flushes and the night sweats, was associated with the increased risk of the cardiovascular disease. Vasomotor symptoms with the onset before or after menopause were also associated with the increased risk of the cardiovascular disease. Psychological symptoms are also there in the menopause. Patient, the irritability can be manifested as irritability, mood swings, poor memory, loss of concentration, low self-esteem, and certain musculoskeletal system or symptoms are also observed in the postmenopausal female as a backache and the joint pain. Regarding cognitive function, memory problem are common complaint of the perimenopausal and the recent postmenopausal women. The increased frequency of the cognitive complaint in the menopausal women suggests that the memory problem is this population related to menopausal transition. and not due to aging, and also due to aging process, and maybe the consequences of sleep disturbances secondary to nocturnal hot flushes, or as a result of effects of changing hormonal milieu in the brain region that influences the cognition. Estrogen plays an essential role in the neurobiology of the cognitive processing and the neuronal function, and the menopausal transition is associated with a subtle cognitive decline. However, the relationship among the decreased estrogen level in the menopause, the effect of the hormone therapy in cognition, and risk of dementia is still conflicting and puzzling. However, the cognitive decline occurred at a greater rate in the women with a low estradiol level. Similarly, a beneficial effect on the cognitive decline has been observed only in women negative for the gene associated with the Alzheimer's disease ApoE4 gene, which code for E4 allele of the glycoprotein known as apolipoprotein E, which has one of its functions, the settling of the lipid during the neuronal repair. These are the certain evidences showing the relationship between the menopause and the cognitive decline. After adjusting for age, cognitive performance during the post-menopause tended to be lower than that during the pre- and the perimenopausal period, particularly verbal delayed memory and the executive function, which involve cognitive domains that are assumed to be more sensitive to the changing estrogen level. The second evidence shows the several studies have also reported that prolonged lifetime estrogen exposure results in better cognitive outcomes. A younger age at the first menses, older age at menopause, age at birth of the first child, more than 20 years, and the extended reproductive period were related to more remarkable performance on the neuropsychological test at the post-menopause. Interestingly, patients who underwent bilateral oophorectomy before menopause had a higher risk of cognitive impairment over time than age-matched natural menopausal women. Additionally, oophorectomy at age less than equal to 45 years was associated with the increased risk of dementia. Regarding mental health, more than 85% of women experience the menopausal transition without mood changes. Some, however, at the greatest risk of the new onset depressive symptom, and this is probably enhanced by hormonal variation in the vasomotor symptoms. Premenstrual syndrome during the reproductive years is a strong predictor of depressive symptom arising in the menopausal transition. A negative view of the mental health at the time of menopause is not justified. Many of the problems reported at the menopause are due to life events, so their causal relation with the estrogen is unlikely. And finally, the summary of today's talk is menopause, a wake-up call. Menopause transition is the time to think about the healthy aging. Prevention and early detection of CVD, osteoporosis, and cancers are essential, and annual health checkups should be performed on the regular basis. Thank you.
Thank you, Dr. Ranjana. It was a very, very informative talk on consequences of menopause. Now, moving from basics to consequences, we'll learn something about management of menopause and their symptoms. So, our next speaker is the very renowned Professor N. Hepzibah Kirubamani. She has been former superintendent of Stanley Medical College, and she worked as professor in Savita Medical College. She has been past president of Obstetrics and Gynecology Society of Southern India. She is at present president of Chennai Menopause Society. She has been past Indian Menopause Society Education Committee chairperson. The list is quite long. I think we all know about her. She is very renowned, very learned speaker. So I'll be handing over the screen to Hepzibah ma'am.
You can, Josna, you can stop sharing so that I can share my screen.
Yes, yes, yes.
Are you able to see my screen?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay. Thank you for the wonderful opportunity to share my thoughts. There was a wonderful lecture on basics and the consequence. We'll move on to the management. The management of menopausal symptoms is three things. For any individual, they also require, though they get old, They have to have a proper diet, nutritional supplements as per recommendations, the physical exercise, which they very much lack, and certain lifestyle modification, and MHT for symptomatic women. Please note, it is only symptomatic women, not for everyone. What minute? So how to live with menopause? So 1/3 of their life they are having after menopause. So like any other person, they have to have a balanced food. This is the pyramid, which we all know. We have to mind our food during older age group, more of cereals, vegetables, fruits, and less of fat and sugar, right? So the sugar should be minimized, the salt should be minimized, more of fruits, vegetables. See, they don't drink water at all because they are fear of going to toilet and they are having some problem in walking. But this is the main cause for dehydration and the stroke. So a lot of indigenous things are also is very good, like cinnamon, flaxseed, it's all, and almond, walnut, dry food is very good. And the foods that are rich in phytoestrogen like lentil, beans, Bengal gram, and soya is very good. So if your mother or a grandmother is having old people at home, please recommend to take plenty of water, fruits, vegetables. So they have to cut down the tea, minimum 3 cups, and avoid more than 200 milligrams of caffeine. Consume 500 to 600 ml of milk or curds. Supports certain fruits and vegetables, which is in favor of vitamin C, so that their calcium absorption is good, right? The tea and coffee should be cut. And in simple rule, the salt should be reduced, so sugar should be reduced. We should avoid saturated fat, sedentary lifestyle, avoid smoking, alcohol. You have to stop. We have to overcome the stress, right? Okay. So the recommended calcium, all old people require calcium and vitamin D. The daily requirement is 800 to 1200 calcium, vitamin D, international units for 1500 to 2000. Individuals who have more, you all know, when the vitamin D is available, the calcium absorption is good. So the D calcium levels about 800 milligrams per day. Mere healthy diet can give you 800 milligrams of calcium. So when a patient comes, you have to assess what is the daily intake of calcium-rich food, and based on that, the remaining thing you can supplement. So the diet supplement assess the daily intake, and so that the supplemental thing we can be very carefully calculated, which can prevent the cardiovascular events and calculi, and kidney stones are not will not occur. So the limit of calcium is 500 milligrams at one time from food or supplement. It should be spread throughout the day. Start supplementing with 500 milligrams of calcium daily for about a week. Gradually, you can increase or reduce to the according to your needs. Okay. So we are all vitamin D deficient people, though we are in a tropical countries. And moreover, the intake sometimes is very less. A low exposure to sun, dark-skinned people are more prone for vitamin D deficiency, pollution, and thyroid hormone, overweight, bypass surgery if they have done, when they have allergy to milk, and digestive diseases like liver, Crohn's disease, they are all more prone vitamin D deficiency. So if you want to expose and get a good vitamin D from the sun, you have to expose 20% of your body surface at least for 30 minutes between 10 a.m. to 3 p.m. So we don't expose ourselves. Either we stay at home, even when we go out in a bike or something, we cover everything. So we are all vitamin D deficiency. So how do we manage? And vitamin D tablets, 6 lakhs week for 8 weeks, preferably with milk, or IM injection can be given to correct deficiency. And maintenance therapy or supplement is advised after correction of deficiency. So maintenance therapy will be a tablet or a powder, 60,000 once a month in summer, twice a month in winter. Vitamin D by oral spray or oral tablet, 2,000 international units per day. And injection cholecalciferol is 3 lakhs twice a year or 6 lakhs once a year. So cholecalciferol 1,000 daily will raise blood level on average 10 nanogram per ml. So this is about the vitamin D and the calcium, how to give the supplements. So coming to the lifestyle modification, and they said psychological problem, mental well-being. You have to be a learner, continuous learner. Even if your mother and grandmother, you can advise them to learn certain new language. They can have some hobbies. So they have to converse with their friends. Then they need to have a pets so that their mental well-being, mental alertness will be good. So, of course, all old people, by then, they are very spiritual, and it will have a positive attitude. And of course, by the time they reach that age, they live without expectation. So, and emotional bonding, emotional well-being, when you get involved in some sort of social work, when we involve with the person, when you converse with the person and with the family and friends, you will have a better emotional well-being. And this is very important. They confine to the bed or the chair, and walking is the best exercise. This raising the hip from the bed, it is continence will improve. So if a recommendation for physical activity and exercise should be an aerobic, muscle strengthening, breathing and balancing. 30 minutes quick walk 5 days a week is very good. Muscle strengthening activities we should advise. For fitness, 30 minutes. For prevention of weight gain, we have to walk 60 minutes. To avoid regain, 60 to 90 minutes. See, look at this old lady with all this hunch and other things. So this will increase her mental well-being, and the physical exercise will promote the strengthening of the muscles. So whenever time comes, please, all old people should dance. So what are the benefits? Helps to maintain a healthy weight, increase in metabolic rate, improves bone density, coordination, muscle strength, improves lipid profile, improves genitourinary problem, relieves depression, induces sleep, overall improves your quality of life. So lifestyle, then they talk about sleeplessness. So they have to have a proper lifestyle, sleep hygiene. They have to go to a particular time in a quiet, comfortable place. They have to avoid large meals, exercise, caffeine, nicotine, and all that 2 hours before sleep. And some people have the habit of have a wash in a warm water. That should be avoided. Dim light, it's better to have, and no gadgets around it. Okay, so that is the thing. Coming to the hormonal management. See, this lifestyle modification, diet and exercise is applicable to right from childhood to menopause, old age. Then coming to the specific treatment of menopausal hormone therapy, it is mainly meant only for symptomatic people, not for everyone. So there are different types of this thing. See, we don't call now there is a hormone replacement therapy. The hormone replacement therapy, when they have premature ovarian insufficiency, they have ovarian insufficiency, so you replace it. And it is renamed as menopausal hormone therapy because estrogen therapy, estrogen progesterone therapy, androgen therapy, menopause, there is a deficient, so we have to give menopausal hormone therapy. So sometimes we give estrogen and progesterone, and this progesterone indication is after surgical menopause. After removal of uterus, no need to give progesterone. But in certain conditions, even without the uterus, we have to give progesterone. There is when there is a endometriosis, frozen pelvis, when there is a residual endometrium following endometrial ablation, supracervical hysterectomy, stage 1 and 2 endometrial carcinoma. So in that case, we have to give progesterone even without uterus. So these are all the list of drugs we are using it now. So the menopausal hormone therapy is most effective in vasomotor symptom, urogenital atrophy. It prevents bone loss. It prevents joint and muscle aches, sleep disturbance, sexual dysfunction. Of course, it corrects estrogen deficiency and maintain vaginal health. Okay. So who are all the candidates we have to choose? Only for symptomatic management. When there is no symptom, we need not give menopausal hormone therapy. And it should be highly individualized based on the cardiovascular risk and carcinoma breast risk. So they should be less than 30 years within 10 years of menopause. Then only the risk is low. And systematic menopausal hormone therapy is not recommended for breast cancer survivors. And one thing you have to remove, it doesn't work for dementia. So you have to select the candidate. They should be symptomatic, less than 60 years and 10 years of menopause. Anything urgent? Anything urgent? Okay, please call me later. So this is the thing. The first line of management, when the uterus is intact, we have to give estrogen and progesterone to prevent endometrial hyperplasia. And when there is post-hysterectomy, no need for progesterone, only in few conditions, even without the uterus, the progesterone is required. So we should choose a symptomatic patient less than 60 years. So there are a lot of types of estrogen, which is used in menopausal therapy. 17-beta estradiol, estradiol, conjugated estrogen, and all synthetic estrogen is used in oral contraceptive, which we don't prefer. Only this, which mimic natural estrogen, it's better to use in menopause patients. So there are when we look at the route of administration, it can be oral, transdermal, or vaginal. Similarly, progesterone also can be oral, vaginal, or intrauterine. There are a lot of dose variation, low dose. We prefer to start with the low dose for short duration, any menopause therapy. So there are different strengths are available, ultra low, low, standard, and different types of estrogen are also available in the market. So as I told you, the route, the oral, transdermal, the transdermal route is a lot of advantage when we use the estrogen. It has got a neutral effect on triglyceride, C-reactive protein, sex hormone binding globulin. We can give it in a migraine patient also and a when controlled diabetes patient also. Transdermal estrogen has got a lot of benefit. Okay. So these are all the conditions we use transdermal, like the control hypertension, existing gallbladder disease, obesity, smoking, venous thrombosis, previous history of venous thrombosis, and sometimes people will prefer transdermal because when they have the patch, they can keep it for 1 week. So they the personal preference also. So I already told you the progesterone can be a oral form, vaginal route, or through the LNG, IUS can be given. So how do we give the type of estrogen? It can be either continuous sequential or continuous combined. In continuous sequential, estrogen is used every day with progesterone added for last 14 days. They will have 80% withdrawal bleeding. This can be given in perimenopause age group. In postmenopause, it is a continuous combined. A fixed dose of estrogen and progesterone are administered every day. Even with that, sometimes there is a spotting and bleeding can occur for first few minutes. So how do we choose? So in perimenopause, monthly cycle, that is a continuous combined regime we have to give so that they'll be happy that they have a withdrawal bleeding. In postmenopause, continuous combined therapy, which induces endometrial atrophy. This progesterone induces endometrial atrophy. In premature insufficiency, there is an insufficient. So we even can give oral contraception, but they require a high dose of estrogen. So 2 milligrams estradiol valuate, 17-beta estradiol can be given with progesterone. It can be a sequential also. So the role of progesterone is that we all know the appropriate, this thing combining with cyclical continuous or this thing, it reduces the endometrial hyperplasia. There is a lot of studies to support this. And vaginal estrogen, when to give? It is indicated in vulvovaginal symptoms, recurrent urinary tract infection. See, people will come with the urinary tract infection-like symptoms, recurrent burning, menstruation, something like that, but the culture will be negative. Those patients will be benefited with local estrogen therapy, overactive bladder, and some we all use before prolapse is posted for surgery, we use the estrogen green. So we always start with smallest dose with shortest duration and weekly for 1 week, then twice weekly, maximum 12 weeks, and we can taper it or abruptly we can stop it also. So this is the thing I was talking to you. So when we give vaginal estrogen, no need for endometrial monitoring. So advantage, what are the advantage in local application? It avoids enterohepatic circulation, no endometrial stimulation, no need for progesterone, no systemic side effects. Its action is mainly local. So coming to the vasomotor system, the best treatment for vasomotor symptom is the estrogen. Estrogen therapy is the gold standard. And of course, the smallest duration we have to give, less than 60 years. Women should be reassured that complication is very low and young postmenopausal patient can take this boldly for if it is continuous, cumbersome problem, we can even give for 5 years. So for any other molecule, they have problems. Some side effects are there. With again, menopausal hormone, we are worried about DVT, breast cancer, coronary heart disease, stroke, pulmonary embolism. These are all the problems. The main issues, the extended menopausal hormone therapy may increase the risk of breast cancer and may increase the use of menopause, may increase the risk. This is the very much concerned with the breast carcinoma. Let's see what is actually the WHO study gives a warning. After that, everybody started not to use. This is the report by WHO report. That is a breast cancer increase, coronary heart disease increase, stroke and VTI is increased. This is the report given by them. Following that, our prescriptions has totally fallen. More than 66%, they do not write hormones. But there was a subsequent publication. They have re-evaluated the same publication. Further analysis shown there is no increase in the heart disease in women starting with HRT within 10 years of menopause. So in that study, they have chosen all old people and the progesterone they have used also is different. So the large control trial following this, taking this after menopause has reduced the risk of the heart disease, dying of heart disease. This is the subsequent publication they have told, and they said it is not that thing. There is a better. So there is it is actually when they did a study, it is our fortune. It shows there is no increased risk of breast cancer and the mortality due to cardiovascular disease. But lot of studies shows we cannot give them estrogen for cardiovascular prevention, either a primary or secondary prevention. There is no benefit at all by giving estrogen. So the risk consideration, the hormone therapy is not indicated for primary or secondary cardiac protection. There is a lot of studies, even the guidance says no need to give for the sake of cardiovascular protection. So there is a strong evidence, again, lot of evidence says it increases the risk of stroke and VTE. So we should not give for the sake of cardiovascular protection. But there is a beneficial effect. When you start them earlier, there is a window of opportunity. See, one lady is having perimenopausal AUB. In that time, when you put estrogen around 38 or 34, if you put them on menopausal hormone therapy, the atherosclerotic patches has not started. It is very clear. Only due to the aging and other thing, the atherosclerotic patches have already started and it has uploaded. So when you go and give that old people estrogen, then it increases the risk of cardiovascular risk. If you start them early, it is a beneficial effect on the cardiovascular. That gives a window of opportunity. In perimenopause, you can put them on some amount of estrogen when they come for some other problem. Effects on stroke. See, it increases the risk of stroke, and low dose. In those cases, they are prone for risk. We can put them on transdermal estrogen or ultra dose, and risk increases when the age is less, and transdermal avoids it can avoid the stroke. So coming to the breast cancer, the two main concerned about the menopausal hormone therapy is the incidence of breast cancer and incidence of cardiovascular disease. Actually, it depends upon the type of the hormone we have chosen, the dose, duration, regimen, route of administration, prior exposure. That is the so the breast risk increases depending upon the so many factors. So, and it increases the difference between MH regime may be associated with increase. See, the tibolone also increases the breast density and obscures the mammographic interpretation. These are all that reason. So what we see the evidence for menopausal hormone therapy in breast cancer, actually the progesterone is the one which is the culprit. That is the greater risk for cancer than the estrogen. That is the progesterone which causes increase in mammary tissue and DNA error, and that causes the malignancy. So we have switched over from synthetic progesterone to natural progesterone. So these are the evidence how it increases because of medroxyprogesterone acetate they have used, and that is the reason the incidence of breast carcinoma increased in WHO study. So we have switched over to natural estrogen. So there are different studies. All these studies, the breast tenderness, breast cancer were not increased in NAM study when they did a conjugated estrogen plus vaxitoxafen. And estrogen increase lesser risk. When it is increased duration, then it increases the risk. So different studies shows, which depends upon the type of the estrogen, the duration, the regimen, what we use, what the combination and all. So there is no need for fear. When we counsel, you have to tell them. So can we use this menopausal hormone therapy with the symptom patient in cases of endometrial carcinoma and ovarian carcinoma? Yes, we can use when the surgically treated endometrial carcinoma, if there is no other option, grade 1 and stage 1 we can give. Similarly, found no, even after ovarian malignancy, data are very much related. So we have to concurrent consultation with the oncologist before using estrogen, because these are all hormone dependent tumors. So before starting, we have to consult with the oncologist also. So coming to the dementia, it doesn't have any effect at all. It neither prevent nor treat the cognitive functions. So the osteoporosis is the useful drug. It prevents the bone loss, and between 50 to 60, it is very safe and very effective in prevention and related fractures. And even in low risk family, it is very, very useful. So coming to the next group of drug, it is a tibolone, which has got estrogenic action on bone and vasomotor symptoms, progesterogenic and anti-estrogenic on endometrium and breast, androgenic action also in mood and libido. So the specific indication, when there is a mood or libido is affected, then we can give. But his endometriotic patient is very, very useful. Fibroid, these are all the. But now they say when there is a history of breast cancer, we should not use Tibolon. And within 1 year of menopause, it's better to avoid Tibolon because it causes irregular bleeding. And the dose is 2.5 milligrams daily as a single dose. Even 1.25 is effective. There are few contraindications when the patient is having hypertension, stroke, diabetes, suspected breast cancer, previous recurrent thromboembolism, we cannot use Tibolon. And the raloxifene is the agonist against bone and lipid metabolism, antagonist against uterine endometrium and breast tissue. So it is useful in osteoporosis, 60 milligrams once daily, which can be administered. And so other certain drugs, non-hormonal drugs also we use to relieve menopausal symptoms like gabapentin for vasomotor symptom when the estrogen is contraindicated, venlafaxine, paroxetine, and few isoflavine also when estrogen is contraindicated. But this lycopene, isoflavine, the evidence is very, very less. So these are all the non-hormonal treatment we can use. Testosterone, it is the evidence is based on the sexual dysfunction we can use in physiological levels. It is not associated with any adverse effect. If you can try for 6 months. If there is no benefit, when they have a libido problem and sexual desire disorder, after 6 months, if there is no improvement, you can stop it. The preparations are transdermal and it is approved by FDA. So when we start giving menopausal hormone therapy for symptomatic women, we have to have a proper dialogue, proper explanation to them, and documentation is very essential. And all medical conditions to be checked and ruled out. We have to clearly indicate what is the dose, how long you have to follow her up. All these things should be documented. Any contraindication, we should not prescribe them. These are all the contraindication when there is a hormone-dependent cancer, breast cancer, abnormal vaginal bleeding, undiagnosed liver disease, family history of venous thromboembolism, systemic lupus erythematosus, are all absolute contraindication. Sometimes we use with caution migraine and superficial thrombophlebitis and family history of breast cancer when there is no mutant gene is available. Uterine fibroid, endometriosis, gallbladder disease, we can use them. So when to stop? When a patient is put on migraine, when she appears first time and a headache is worsened, blooding or fission, you have to join. In gallbladder disease, if she develops jaundice, you have to stop it. On the patient, when she develops hypertension during your treatment, you have to stop. Okay? And hormone therapy, when the patient is on estrogen, you have to stop before 4 weeks for elective surgery. If they require a constant follow-up, after prescribing, immediately after 1 month, you have to ask them to come back for efficacy and side effects. And again, routine investigation like blood pressure, clinical examination to be done. After 3 months, then annually you have to ask them to come. And during annual checkup, you have to rule out ultrasound to evaluate pelvic pathology, and we should review any new disease would have come. So ultrasound and mammogram should be repeated. So the duration of therapy in premature menopause, wherein insufficiency, we have to give till the age of natural menopause. And others, the safety data says estrogen progesterone up to 3 to 5 years and estrogen alone up to 7 years, they have the documented. So we can, but the basic rule is short duration, short dosage. We have to start. If it is responding, we can even stop it. So if you want to extend after 1 year or something, it should be a shared responsibility. And we have to get a counseling, all those things, informed choice. So we can stop the drug either abruptly or taper it down. So the benefits, risk versus benefits. When the women is less than 50, the benefit outweighs. Between 50 and 60, the benefits also outweigh. 60, there are equal risks. The treatment should be individualized. After 70, the risk is more. So you have to choose the patient, the age group between 50 to 60, less than 10 years of menopause. So the wisdom trial says it should be given for symptomatic women up to the age of 55, the usual age when they are oophorectomist, for prevention and treatment of osteoporosis after menopause. 5-year duration appears to carry no increased risk of breast cancer. Alternative proven therapy should be chosen when they have a long-term prevention. So weighing the benefits and the risk, as already mentioned, the maximum benefit when you give less than 60 years within 10 years of menopause. So the best treatment policy, best treatment policy depends upon the women's age, women's risk, women's symptom, available treatment option, the cost of the product also it depends. After examining and understanding her situation, and she will require periodic evaluation. So nearly previously the signals are confusing. So now it is very clear. It is indication for menopausal hormone therapy is after 60 years or more than 10 years as a complex risk and requires careful consideration. So within 10 years of age, it is better. Previously, we were talking about prevention and generalization. Now it is highly individualized, right? So the current prescription should be begin with the lowest effective dose for shortest duration and between 50 to 90 only for symptomatic women. So no longer it is everyone should prescribe, everyone should receive. It is highly individualized and should be for symptomatic women. So menopause is, it is really a challenging thing to treat. And now we will see more and more of aging population in our country, and with the eroding tradition and nuclear family, and people will be suffering in silence. So we don't have a trained person. So all of us should get trained in menopause women treatment when they have symptoms. So a young woman is a gift of nature, but an old woman is a work of art. So we always believe everything should start fit at 40, strong at 60, independent at 80. We can age, so that we have to age gracefully. Everything should start at 50. So everything should start by midlife. Whether I do not know whether this video is working, and let me try. Let's see. Hello?
Yes, ma'am. Yes, ma'am. We can see the video.
How the midlife woman's life is being. So that's about the midlife. That movie was done by my student. Hello? So the right decision are the hardest moves to the, especially when the choices are many. The secret of success to make right decision is experience. So for menopausal hormone therapy, we have to choose the right woman, right age, right type, right dose, and right room. So thank you for patient listening.
Thank you, ma'am. Ma'am, we received
Can
three,
switch on the videos?
ma'am, we received 3 questions from YouTube live chat.
Yeah.
So the first question is there any role of doing FSH, AMH, estradiol to diagnose
To
menopause?
diagnose menopause, it is clinically no need for FSH. It shows erratic. So it is only clinical diagnosis. 12 months of amenorrhea is enough. Only for premature ovarian failure, all these things, insufficiency, we have to require all these things.
And then the second question is, what conclusion can we get from a straw classification?
Strauss classification actually divides the life of a lady into a reproductive age group, early menopause, and other things based on endocrine, FSH. But Ankaleshwari modified classification that is based on clinical conditions. That is divided into 1A, 2, like that, based on the symptoms, so that we can do either a preventive aspect, treatment aspect, palliative treatment. Something if the lady falls under menopause age group, it's only a palliative treatment. In perimenopause, if she has vasomotor symptoms, there is a window of opportunity. You can treat and her bone can be saved, like that. When there is during 50 to 60, the treatment options will come. That modified Ankaleshwara classification is much more useful for our clinical practice. It is based on clinical data.
Then the third question is,
all of us can share the video, can switch on the video so that we can take a photo as if we are in person. Ranjana, Josna. Yes, madam. Jyoti, switch on the video. I can take a photo. Yeah, one more question.
yes, ma'am. Any role of OCP in MHT?
No, MHT is totally different. Don't get confused with the OCP. OCP is OCP. It is for contraception.
Yes.
Right.
And one more question.
Therapy,
Yeah.
that we don't prefer synthetic estrogen, either conjugated estrogen or 17 beta estradiol, which mimics endogenous estrogen. That splitting, getting, going to liver, this and all is there. So the efficacy is more. So conjugated estrogen, the load on the liver and other things is, we don't prefer that age group.
Then, ma'am, the last question is, even after regular vitamin D and calcium flavonoids, BMD shows severe osteoporosis. Please suggest further medicine to combat osteoporosis.
Yeah, when there is a severe osteoporosis, when they are with the vitamin D and all, they have to treat the osteoporosis. Okay. So
Yes.
bisphosphonate and other things.
Okay, ma'am. Thank you so much for giving all the answers, ma'am, for these questions. I hope delegates have got their answers. Thank you so much, ma'am.
Thank you. Thank you, madam.
Thank you, madam. It was a very, very nice presentation from you.
No, you
And I think everyone.
Shall I stop the live now?
Your assistant professors, I learned from your assistant professors.
Thank you,